Today we are going to demonstrate the examination of a bony swelling. Introduce yourself and gain consent.
नमस्ते, मैं डॉक्टर अभिषेक हूँ। क्या मैं आपके टांग की जांच कर सकता हूँ?
Expose the patient and wash hands. The examination begins with general physical examination.
The patient is conscious, oriented to time, place and person, moderately built and lying comfortably on the examination couch.
Examiners usually ask if there is any significant finding in general physical examination. If not, then you can move on to inspection.
On inspection, there is a single spherical swelling over the anteromedial aspect of proximal leg extending from tibial tuberosity to the medial hamstring tendons, approximately the size of a tennis ball. The surface of the swelling is smooth with overlying dilated tortuous veins. The patient can be asked to sit up to accentuate this finding. The skin is of normal color, stretched, shiny, with no abnormality of the overlying hair. Edges of the swelling are ill-defined. The swelling is non-pulsatile. Ipsilateral thigh and leg appear wasted. When seen from the lateral aspect, the knee is in an attitude of flexion. There are no other associated swellings when seen from the medial, lateral, or posterior aspects.
Now coming on to palpation.
The swelling is warm to touch and non-tender on palpation. The swelling is ovoid in shape and approximately 10 by 8 centimeters in horizontal and vertical dimensions. The surface of the swelling is smooth and regular, and it is uniformly cystic in consistency. The proximal and posterior edges are ill-defined, whereas the anterior and distal edges are well-defined. The swelling is compressible but not reducible, and it is non-pulsatile. The overlying skin is easily pinchable and mobile over the swelling. The swelling seems to be arising from the underlying tibia since it is immobile and I cannot insinuate my fingers between the swelling and the bone. Fluctuation is present. Slip sign is absent. Fluid thrill is also absent. After dimming the lights, I have checked for trans illumination. Trans illumination is negative. On examination of the regional lymph nodes, there was no palpable lymphadenopathy in the popliteal fossa and there was no significant palpable inguinal lymph nodes. Examination of the knee reveals restriction of terminal flexion and restriction of terminal extension. Distal pulses are palpable and there is no neurological deficit. On measurements, there is wasting of 5 centimeters and 3 centimeters of the ipsilateral distal thigh and proximal leg respectively.
To complete the examination, percussion and auscultation must be done. Thank the patient and offer to help them cover up.
This is a plain digital X-ray AP and lateral view of the knee of a skeletally mature patient. The AP view shows eccentric expansile lytic lesion in the proximal tibia, which is epiphyseal in location extending up to the metaphysis. There is a cortical breach on the medial side. A thin flake of subchondral bone appears intact. The cavity shows ground glass appearance. On the lateral view, additionally, we can see that there is no breach of the anterior or posterior cortex. However, a soft tissue shadow can be seen posteriorly, which has abnormal extraosseous calcification. Osteopenia of the distal femur is also noted.